This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hi, I'm here with yet another very interesting case. He's a 10-year-old boy who presented to us about a month back, and he presented with a history of the glass bulb blast. And that glass bulb blast had caused an injury to the eye, and he presented with severe pain and redness and diminished vision. On examination, the eye was inflamed and the cornea was severely edematous. However, the globe was intact and the antechamber was very well formed, but the details of the antechamber and the pupil and the iris could not be made out because of severe corneal edema. The B-scan ultrasound, however, showed a normal posterior segment. Now, the treatment was initiated, which was to control the inflammation, and was started on topical antibiotic drops along with the steroids and cycloplegics. And over a period of time, the inflammation subsided in the next couple of weeks, and the cornea also cleared up. But sectorally, the corneal edema still persisted. Almost 75% of the cornea still was edematous. And we started the patient with hypertonic saline so that the corneal edema clears off. The pressures were normal all the time. But by the end of 1 month also, the cornea was much better than what it was. The superior cornea was clear now, but still about 50% of the cornea from center to down was still very hazy. But now there's something which shocked us all. Because the cornea had cleared off now in some areas, we could have view into the antechamber, and lo and behold, to a surprise, we found this glass piece inside the antechamber. It is sitting exactly perpendicular to the cornea. That is, one end is at the pupillary margin and second one is almost piercing onto the endothelium. So the cross-sectional view, we can see that the alignment of this glass foreign body inside. The crystalline lens looks to be alright. There's no rupture of the anticapsule. The lens looks to be untouched as of now. And now we understand the reason for the persistent corneal edema. It was sort of an endothelial decompensation which was setting in, and we were not able to find out the reason. At last now the reason was very much evident. So this needed to be obviously removed at the earliest, and let's discuss how do we do it. So what should be the intraoperative plan to remove this foreign body? Of course, the surgery is being done under IV sedation and a little bit of a posterior subtenance anesthesia. Now, how do we deal with this foreign body and remove it? So let me share with you my plans and reason for planning it in such a way while dealing with this foreign body. There are certain goals which I had to keep in mind. Number one would be to ensure that during the process of removal, the other structures inside the eye, like the crystalline lens, the corneal endothelium, are not touched at all. At this point, I don't know how strongly this glass is adherent to the iris or the cornea, because almost 1 month, I expect an inflammatory membrane, which is ensuring that this glass could be sticking onto the iris itself. So I need to dislodge the glass piece from the ocular tissues and then remove it without causing any collateral damage. So that is the goal here. So the major concern is obviously the crystalline lens here. And I don't want it to slip and go in the inferior part of the angle, so that again it becomes very difficult. The next challenge is, where do I put my incision? There are areas where it is much more nearer, like the temporal side or the inferior temporal side, where we get a quicker access to the foreign body, but there are a few problems. I want to remove it in an angle which is parallel to the foreign body so that not much manipulation is required. And second thing is, because I want the visualization to be very good so that it helps me to grasp the foreign body, I would prefer to make an incision which is superior, because this part of the cornea is clearer. Number two, I don't want the foreign body to slip and go and touch the crystalline lens, because the foreign body is sitting exactly near the pupillary margin. So how do I deal with that? For that, I had a plan of using an intracameral pilocarpine just a little bit, so to bring down the pupillary size. This helps to just minimize the inadvertent touch to the crystalline lens. So the plan is to make a superior incision and then using viscoelastic, dislodge the foreign body away from the iris and the cornea, then align it so that it is parallel to the incision which I have created, and then using a forceps, remove it out. Let's see how things turn out. After giving 1.5 ml of subtenance lignocaine, I'm making a 1 mm side port incision. 0.1 ml of pilocarpine is injected. You can see that the pupil size is coming down. I'm using cohesive OVD like sodium hyaluronate to deepen the antechamber. The second side port is created, and time to perform the main incision, which is planned at 12 o'clock, so that I have got easy access to the foreign body and it can be removed in much more traumatic manner. Although the path is longer to reach the foreign body, but this looks to be the most safest way to approach it, as the visualization will be very easy and I can remove the foreign body in a single go, because the axis of the foreign body is parallel to that of my planned incision. The incision is consciously planned with a very less of a corneal length, so I don't have to struggle to get the foreign body out. The incision is about 3 mm in size. I'm being a little bit generous so that the idea is to remove it in a very traumatic way. The next step which I want to do is to ensure that the foreign body is moved away from the pupil. So I just want to cut down any chance of the foreign body going near the vicinity of the crystalline lens. So using the viscoelastic and the cannula, I'm just pushing the foreign body away from the pupil towards the paracentral region, just to ensure that it is away from the area of a crystalline lens. And at the same time, I also get an idea that the glass foreign body is not very strongly stuck in the iris. It didn't take a lot of an effort from me to dislodge it from its original position and move it towards the side. So now with the same cannula and the OVD being injected to keep the chamber very well inflated, now trying to position the glass foreign body in such a way so that the long axis of the foreign body is parallel to the axis of the incision, so that I don't have any problem in grasping it and then removing out. So if it is horizontal, so I can't hold the foreign body with its long axis being horizontal or perpendicular to the axis of removal. So now we have the foreign body aligned in such a way so that its long axis is parallel to that of the axis of our incision. The chamber is well formed with the OVD. I'm using the regular curved suture tying forceps to enter the antechamber, grasp the foreign body and pull it out. Wow, it was quite easy, right? Definitely it was much more easier than what I had anticipated, but the planning did help it to make it effortless. Now I need to suture the main incision. I'm using tenovical suture to close the wound, as it is absorbable and we don't have to again subject the patient for one more episode of IV sedation. Bimanual I&A is used to aspirate all the cohesive OVD which has been used inside. It takes a couple of minutes to evacuate it. The intracameral cefuroxime is injected and that's it, the case is done. Hopefully now with the glass foreign body which was touching the corneal endothelium being out, we feel that the corneal decompensation which was setting in is halted and the corneal endothelium are going to migrate and the cornea is going to get back its luster and clarity. And this is the third day post-op picture. Still there is a sectoral edema which is present and it is going to take few weeks probably to settle and hopefully the cornea will clear. So this was an interesting case where the detection of the foreign body inside the antechamber was delayed because of the presence of corneal edema. So all trauma cases do throw up some challenges and we need to be conscious and mindful of these possibilities. And with a little bit of a planning, these foreign bodies can be dealt with in a very safe manner. Thank you for watching and hope you found this helpful.